Okay, so we completed reading the RBC morphology part in the last video and comprehensively understood why certain morphologies occur in certain conditions. So there are associated pathologies to every morphology, and we learned that how these pathologies occur in every single morphology. So I tried to make sense on how you can connect both of them and learn the connection between them and keep them in your mind. These are the pictures that can come in your exam, so you need to take a good look at the pictures as well. Now we're going to be looking at RBC inclusions. So first of all, you need to understand that the types of RBC inclusions is basically divided into bone marrow and peripheral cilia. So bone marrow inclusions are basically when you are taking a sample from the bone marrow, that is where you're going to see those inclusions. And for peripheral blood inclusions, you are going to see peripheral blood inclusions in mature RBCs that are circulating in the peripheral blood. So you're not going to see them in the bone marrow. But for bone marrow inclusions, you're going to see them in RBCs that are currently in development in their bone marrow. So the basic difference between a mature and immature RBC is that immature RBCs are nucleated and they might have some nuclear remnants, and immature RBCs are enucleated, which means that they have no nucleus, right? So just to tell you that immature RBCs are enucleated, right? Enucleated means no nucleus, right? So no nucleus. That's what enucleated means. You can see it over here. That is a word that is used for the lack of nucleus. So firstly, bone marrow. What is the only bone marrow RBC inclusion that you're going to see? Those are iron granules. But before starting this, I want to tell you something about inclusions as well. What basically are inclusions? So inclusions are basically deposition in the cell. So if you can see the pictures over here, you can see that these are different depositions that are inside the cell. So basically, let's look at this one. So this is the whole cell and this is a deposition of something. We do not know what it is, but it is something that is deposited in the cell. Likewise, in this picture, you can see that there are very small depositions, right? And this is quite clear. You can see that there is a small deposition there, as well as in these cells. You can see there are micro dots uh, in the cell. So inclusions are basically depositions. So if I could write it, so they are basically depositions, right? That is what inclusion is. That there are different kind of inclusions, but we are specifically focusing on the RBC ones now. So iron granules are the only RBC inclusions, at least the only one that first aid seemed to decide that is relevant for your exam. So iron granules, what basically are they? So this is a picture of iron granules. You can see it in your book also. And if I could try to zoom it, you can see. But it's not really that clear. So that's what iron granules are. These are small bluish depositions in the cell. So that's going to be visible like that. Associated pathology is sideroblastic anemia. And sideroblastic anemia can be caused by lead poisoning, myelodysplastic syndrome, chronic alcohol overuse. The basic concept of sideroblastic anemia is that there is a problem in the formation of heme. Like that's the basic concept of sideroblastic anemia, and that can occur due to different etiologies. So lead poisoning can inhibit an enzyme in the heme formation process. Pherochelatase and myelodysplastic syndrome can also inhibit the development pathway of sideroblastic anemia and cause sideroblastic anemia. Chronic alcohol overuse can cause mitochondrial toxicity. Mitochondria is basically the place where heme formation is being done. So that is why there is perinuclear mitochondria with excess iron, because the process that is supposed to happen in the mitochondria is not happening. So iron goes to the mitochondria. Iron is stored in the mitochondria so that iron can be used. The process of heme formation. So iron is basically used in the process of heme formation. But since this process is not working, the iron starts to deposit in the mitochondria. So what happens is it's iron starts to gather, it uh, begins to be visible, and specifically through Prussian blue stain, which you need to keep in mind. You can visualize iron granules. That's what specifically you can do to visualize iron granules. Prussian blue stain is something that you would need to remember, and you can also you should also keep in mind that the iron granules can sometimes uh, deposit in the manner of a ring. So basically, if this is a cell, right? So what iron granules can be deposited in a manner of a ring like this. So obviously, when you're going to stain these cells, you're going to get a visualization in the middle of the cell, which will be ring shaped. This is what you're going to get. So these will be called as ringed sideroblast, which is what is basically mentioned over here. So they can describe this in a question. They can say that they can give you a case of an anemia. And sideroblastic anemia is a microcytic kind of an anemia, so MCV is going to be low. And they can describe a patient as having any one of the risk factors, and they can say that in bone marrow smear or bone marrow aspiration, not aspiration, in bone marrow smear, after bone marrow aspiration, ringed structures, ringed visuals were observed in the cells. So they can either mention that Persian blue stain was used, or they can just simply mention that ringed visuals were shown. So that's what you need to, that's how you get to the question, right? So this is the only bone marrow uh, inclusion that you're going to see. These you're going to see when you take RBCs out from the bone marrow, basically, right? So keep that in mind. Peripheral smear, you can see in peripheral blood, which peripheral smear is normally taken. So you're going to see these inclusions. Howell Jolly bodies are basically, they occur in functional hyposplenia. So sickle cell disease, or they can occur in asplenia. Somebody has a traumatic injury and they have undergone the splenectomy. The spleen is out. They will also have Howell Jolly bodies. So what basically they are basophilic nuclear remnants. Um, they are usually removed by the splenic macrophages, but since the spleen is not present, so they are persistent in the blood. You can see these are Howell Jolly bodies. Would you clean this picture up for you so that you could look at it? So the ghost spleen is not there anymore. These bodies persist in the blood, and they are present in the blood. Basophilic stippling, you can find it in sideroblastic anemia and thalassemia. So why can you find sideroblastic basophilic stippling in sideroblastic anemia? Because uh, again, these are basophilic ribosomal precipitates. So Howell Jolly bodies are nuclear remnants, and basophilic stippling is basically ribosomal precipitates. So this is a difference. These are because these are blue colored, so they are called as basophilic. So anything that is blue colored is known as basophilic. And they have the basic difference between them and Howell Jolly bodies is that they are ribosomal precipitates. They do not contain iron. And the reason why we have them, the rationale behind them, is because in sideroblastic anemia and thalassemia, there is ineffective erythropoiesis, there is disordered RBC maturation. So that is why we can see them. So what happens is that RBC is usually, as I've told you in the previous video, they have a nucleus and then they start to, the nucleus starts to break into pieces, right? And then the cell also decreases the size and is completely mature and it's released into the blood. Okay. So if this maturation pathway is disturbed, let's say this cell gets released into the blood, then you can obviously see the basophilic nuclear remnants or basophilic ribosomal remnants. The process basically is that RBC is a normal cell at the beginning, and then as maturation occurs, the organelles in the RBC, the red blood cell, they start to disappear. So the more immature a cell is, it will have more organelles or remnants of organelles, such as ribosomes or nucleus. The more mature it is going to be empty completely, because that's what RBCs are made for, to be empty. That is why in thalassemias and sideroblastic anemias, you basically need more production of the RBCs. So due to this fast production and rapid release, you sometimes release a lot of immature RBCs, like this, in which you can get basophilic stippling, right? So in both of these conditions, the patient is needing a lot of cells to compensate for the deficit. So that is why basically you can see this. Even in anemia, you can see reticulocytes. So what are reticulocytes? Reticulocytes is basically an immature form of the RBCs. Not as immature as these, but they are immature form. So the presence of immature form shows us that the body needs RBCs right now, and that is why it is doing rapid production and rapid release of the cells. Pappenheimer bodies are seen in sideroblastic anemia. These are basically just granules that contain iron. Uh, the iron granules were present mainly in bone marrow, but sometimes if they can be seen in the blood, then they are known as Pappenheimer bodies. Some reason they have changed their name. There is no basically rationale for this, and they're just these clusters of ferritin and normal iron-loaded organelles. So there's not really a rationale for what they are. G6PD bodies, classically they occur in G6PD deficiency. They are denatured and precipitated hemoglobin, right? So you need to remember that they're denatured and precipitated hemoglobin. Phagocytic removal of Heinz bodies occurs. Or what happens is that once Heinz bodies are formed, so a neutrophil or phagocyte is going to come and take a bite out of the cell. So it's going to result in this place being empty like a bite. So it would appear as a bite has been taken off and a part of the cell is gone in the bite. So that's how cells are going to appear. It requires supravital stain, which is a crystal violet, to be visualized, right? So crystal violet stain is required to visualize it. This is an important detail that you must remember. And this is it for the RBC inclusions. Now we'll be moving on to the anemias. This flowchart is amazing if you are a beginner, and you don't need to memorize it because you're going to know everything about this flowchart in the upcoming lectures. And the more you study hematology, the more easier this flowchart becomes. But for a beginner, it's very good. So how to approach this flowchart is basically first look at the MCV levels. So you should know the normal MCV level is 80 to 100. That's what you should know. Less than 80 is microcytic. more than 80 is macrocytic. That is easy enough. Just remember the microcytic anemias first because they are four and they are easy to remember, right? Afterwards, go to the macrocytic part. Macrocytic, I've already told you that there is another subdivision which is known as megaloblastic and non-megaloblastic. Macrocytic just means that big cells. So it means that big cells, right? Big cells. That's what macrocytic is. Megaloblastic means that either the presence of big cells is accompanied by defective DNA synthesis, or there's any defect in the DNA, because mostly DNA is defective when there are big cells, big RBCs present. So it is thought that maybe the better way to study this is to, if you find a macrocytic presence in somebody's blood, you further divide it into megaloblastic and non-megaloblastic. So if it is megaloblastic, uh, then there are different etiologies for it, such as folate deficiency, vitamin B12 deficiency, orotic aciduria, and Fanconi anemia. Megaloblastic is indicated by the presence of hypersegmented polymorphonucleosides. If these are present, then you have yourself megaloblastic anemia. If there is no hypersegmented polymorphonucleosides, these are not. If these are not present, then you have yourself a non-megaloblastic anemia. The etiologies for this are diamond blackfan anemia, liver disease, and chronic alcohol overuse. I would suggest to remember the last two because these are most important. The chronic alcohol overuse is the best example. So sometimes they give you a question of liver disease and a patient with alcohol addiction, and they also give macrocytes, and this just completely confuses the student because the student only remembers this arm of the table. They only remember megaloblastic anemia. So macrocytes can be present. Big RBCs, big cells can be present without DNA damage. So after this little point is encountered, then you go towards the normocytic part. So normocytic can be divided into non-hemolytic, hemolytic. Hemolytic, in which there is a destruction of the RBCs by the immune system. Non-hemolytic is when there is no destruction of the RBCs by the non-immune system. So if there is destruction, then of course body needs more cells. It's going to be a high reticulocyte index, which means basically there are going to be more reticulocytes present in the blood, right? Which means there is rapid production of the RBCs, which means there is rapid release of the RBCs, which means that there is rapid release of immature RBCs, which means there is rapid release of reticulocytes, which are immature RBCs. If the body is not destroying the cells, then there is no need for rapid production, and there's some problem in the production. Okay, so then it would be a low reticulocyte index because there is no rapid production. There is some problem in the production. So if you can see that early iron deficiency can cause it, anemia of chronic disease can cause it, aplastic anemia can cause it, chronic kidney disease can cause it due to deficiency of uh, erythropoietin. Yes, erythropoietin. And acute blood loss can cause it. Uh, as you can see, this is a problem in the RBC production, mostly right. After hemolytic is done, there are, of course, there's intrinsic hemolysis, there is extrinsic hemolysis. Extrinsic hemolysis basically means that the reticular and endothelial system, which is the spleen, the macrophages, they basically are destroying your RBCs, right? But when your RBCs are away from the spleen, they have no problem. So that's what extrinsic means. Intrinsic means that they are being destroyed in the blood vessels. They're being destroyed in the blood vessels because spleen is outside the blood vessels. It is a different organ. So that is known as extrinsic. So outside the blood vessel, intrinsic inside the blood vessel. The classical difference to identify them is there's going to be decrease haptoglobulin. This is the common difference. This decreased haptoglobulin in intrinsic. In extrinsic, we're going to have a normal haptoglobulin. That's how just you're going to figure out the difference between them. There are multifarious etiologies. You can read about them. We're going to learn about them in the future lectures as well. So we are reading together these. We have done this section. We have read this together, and we'll be moving on to the pathology, the other pathology sections now.